posterior tympanotomy, canal wall down, and the facial nerve decompression. Dr. Raman Sharma would be demonstrating posterior tympanotomy and then the canal wall down. I expect a lot of questions from participants regarding canal wall down because that's the commonest procedure that everybody does. So no question is a stupid question. Whatever comes to your mind, you must ask the question. Don't go back with your doubts, clarify them. Uh, Dr. Raman, over to you.
Thank you, sir. So, can we have the delegates, please? Please come forward. So, good morning, everyone. We'll start with the demonstration of Canal Wall Down procedure. So, we don't want to compromise your time of dissection. So, please, as early as possible, please come and we'll do the demonstration of posterior canal wall down. So, in brief, what is canal wall down procedure? It is nothing but we are lowering the posterior canal wall so that the mastoid bowel, it is exteriorized to the external auditory canal. So nowadays, I also don't prefer to do canal wall down procedure. There are very few indications. So the advantage of doing posterior canal wall is that you have a good access to all the hidden areas, or as a part of the skull-based surgery, you have to do a canal wall down procedure, or if you have to do a facial nerve decompression, then also sometimes you have to lower the canal. Now, the canal wall, why we don't prefer the canal wall down? Our main purpose of doing a mastoid surgery is to give a disease-free ear, right? That should be our first priority. We should explain to the patient. Second is hearing reconstruction or giving the hearing result. So our canal wall, it gives a hearing gain of almost 15 to 18 decibel to the patient. So if you are lowering the canal wall, so you are giving a hearing loss, some amount of hearing loss to the patient. And there will be difficulty in adjusting the hearing aids or post-op rehabilitation. Second, if you can do the canal wall down, so the cavity problems will be there. So since the labyrinth is totally exposed, the patient will feel dizzy or there will be a discharging cavity. So to avoid those problems, people are doing mastoid obliteration procedure. There are different things which are used for doing mastoid obliteration. So now most of you have done your cortical mastoidectomies. Today you have to perform canal wall down. Before canal wall down, what you have to do is, you do the posterior tympanotomy also. I need a circular knife. Okay. So before you do your canal wall down, or in the cortical mastoidectomy also, you need to expose your posterior canal wall fully. So this is the tympano squamous and
Dr. Raman, little bit centering is required.
Yes, yes. I'll just raise the flap, then I will centralize it. Knife. Knife, blade. Keep guiding me, sir, in between. Leave it, leave it, leave it, leave it. So I'm doing the, I'm just giving the radial incision so that I can antepose my posterior flap and to have a better circular. So whenever you are handling the flap, use a smaller microsuction tip so that you don't tear it. So this is my flap. Here is the tympano squamous suture from where it is sometimes difficult to raise the flap. Okay. Since it's a cadaveric dissection, we can remove this flap. We don't need this flap. Okay. This is the tympanic membrane. So we did stepidotomy also in this patient yesterday. Posterior tympanotomy, may I know? Sir, we have done stepidotomy in this patient. Okay, okay. Okay. So for the posterior canal wall, now I need a large size bar. So your canal wall, I can see some defect in the posterior canal wall. So this can happen.
Dr.
So
Raman, can you lower the magnification where I have better orientation? Yeah. What magnification you are using now?
it is 10, sir. Now I'm on to
Yeah,
6.4.
This is better orientation.
Okay. So to avoid this canal injury, you should use an adequate size of burr. The adequate size of burr is when your burr should not touch two adjacent surfaces. It should touch only a single surface. And whenever you damage the canal wall, always try to replace it with the cartilage. So now I have to thin out my. Now I'm planning to do a posterior tympanotomy, and my wall is quite thick. So first I need to thin out my posterior canal wall. So you have to open it like a book. So this is one flap of the book, this is the other flap. So you have to open it. You have to open it, only then you will be able to access the posterior tympanotomy area. There is some whitish structure I can see. I don't know whether you are able to see or not. This can be a facial nerve. No, it is not. So you thin out the posterior canal wall uniformly from above till lower. And whenever you are planning to do a posterior eticoeditotomy, you have to drill this ledge of bone, cortical bone, towards the zygoma root, so that you are able to see the incus shadow and the light can go there. And here your approach should be from inside out, in this way. In the yesterday's procedure, I think we have the incus has been removed while performing the posterior stepidotomy. So we will not be able to see the incus shadow over here. Okay. So you can dissect the mastoid cavity till you are able to see this honeycomb appearance or the air cells. So it is safe to dissect. Sorry. Lateral semicircular canal, sir? No, no, sir. It is right here. So this is the sinodural angle. If I go, I don't think this area you are confusing, sir. This one, this defect, small defect. No, sir. It is quite a thick bone. I don't think we. No, sir. I don't think so. Let us explore. मैं खुद करूँगा, मेरे को बता देना। हाँ हाँ, मैं माइक्रोस्कोप से करूँगा, बोन से मत करो। राइट। So I'm thinning out the posterior canal wall. So to identify the facial nerve, there are two approaches. Either we can go from distal to proximal or from proximal to distal. So you should try and identify the facial nerve in its mastoid segment, then you go upward. Because if you try to identify somewhat here, you tend to damage the facial nerve. We have diamond burr. Yeah, smaller size diamond burr.
Dr. Raman, is there any slight buttonholing of the posterior canal?
Yes, it was already there yesterday
Okay.
when eticoeditotomy was done.
The commonest question with the postgraduates is what's the bridge and what's the ridge?
Yes, sir.
Please do explain to them so that everybody understands on the board.
Yes, sir. First, I am doing the posterior tympanotomy. After that, I'll do the lowering of the, breaking the facial bridge and lowering the ridge. So when you start doing posterior tympanotomy, so leave a small ledge of bone known as incus buttress over here, and then start drilling here parallel to the facial nerve. So once you see the shadow of the facial nerve, you can shift to a smaller size burr. Posterior tympanotomy is usually 2 to 2.5 mm. Opening we create, yeah, smaller size burr. So this could be a facial nerve. Can I see? Can I have a needle? So this could be a facial nerve. Yep. So you leave a ledge of bone over here, and then keep dissecting, keep going medially, anteriorly and medially.
So I think in live surgery, we would see a shadow of a vessel over the facial nerve also. We see the vasa nervosum also. So it is easier to identify a fallopian canal in live surgery. There will be a small vessel which will follow the course of the vertical part of the facial nerve, which will not be visible in your cadaver.
You should know what is the course of facial. It is the line between the lateral semicircular canal to the digastric ridge. You have to drill in that direction, parallel to this, and then there is a pinkish hue in a live surgery. As you rightly said, there can be some bleeding also. So that is perineural cells can be there, and you can have a idea that yes, you are about to reach the facial nerve.
Water. Water.
Good morning. We welcome Dr. Yadav. Sir has just joined us.
Smaller size bar.
Perifacial.
Yes,
And
water.
that Herald cell is anterior or that is medial, much medial. So if it is there, then you are sure that facial nerve is not going to be damaged.
Yeah. Water. So while doing posterior tympanotomy, don't go lower down because there will be a cordofacial angle which you can damage, and
Yes.
chorda tympani is very much closely associated,
So
related to the annulus. So you may actually damage the annulus, bony annulus.
So the antrum threshold angle is there. So you should stay closer to the upper end. There it is wider and you will have more space to enter the middle ear.
Centralize. Right. So when you are doing a posterior tympanotomy, don't work in a narrow hole. Keep shallowing your area around so that adequate light goes inside. Needle.
What is that? वो रमन ये white ये facial आ गई क्या?
So facial is mostly, this is the facial.
हाँ,
So
ये
I'm going
कौड़ा आ गई
needle.
है. कौड़ा
This
है.
could be chorda or bony annulus.
तो उसको थोड़ा सा ऊपर करो.
Yes, I'm. Is it centralized now?
हाँ, it's well centralized.
Okay. But smaller size.
As Dr. Raman is very beautifully demonstrating, we can see at all times we should have all the landmarks in our view. The posterior canal wall should be under your view, the incus buttress should be under your view, the external auditory canal should be under view, facial nerve and chorda tympani. All these landmarks should be under your direct view during at the time of doing of a posterior tympanotomy, so that you always have a hint where are you going and where the drilling should be modified.
So don't worry if your facial is exposed, but you should not damage the capsule or the sheath of the facial nerve. Even it is exposed, you don't need to worry about it. Sometimes to have an access to round window niche, you might have to extend posteriorly. Since incus is not here, it is a very important landmark to do the posterior tympanotomy. So I'm just doing by mere imagination. So I've entered into the middle ear. Now, after opening or entering into the middle ear, our next landmarks are we need to see the round window. Before visualizing the round window, we need to see the IS joint blocked. So landmarks after posterior tympanotomy, you should be able to see the pyramid, the stapedial tendon, IS joint, and you can confirm the IS joint by moving the incus, which you were seeing in the uh, additus area. And then you try and look for the round window niche. So if you are not able to see the round window niche, you can actually break that incus buttress, or you can go more anteriorly. If you are compromising the chorda tympani, then also it will increase the excess. This is known as extended facial recess approach. Yeah, thank you. So all this bone I can drill further, but in view of paucity of time, I won't do much. We'll just look for the, I need a wash. We'll just look for the round window. Since incus is not there, stapes suprastructure is not there, so we will not be able to see all the landmarks. I hope you all can see the round window shadow there,
Yes,
round
it's
window
visible.
niche.
Yes, it's visible. We can drill more posterior ledge of the bone. Yes, it's visible. Beautifully visible.
Okay. So now, before we wasting much of your time, let us finally. So a tip just for the delegates: if you are a beginner, once you open the antrum and you see the incus shadow, try to preserve that incus body. Try to preserve that incus body, and you should not touch your burr on the medial aspect. If you are touching the medial aspect, you tend to damage the second genu of the facial nerve, which is the most common site of injury in the cortical mastoidectomy. So just keep your burr above
So just
the
a bit,
incus.
can we center, slightly center?
Yeah.
Raman, I think the lateral semicircular canal is open here.
This one, sir?
Yeah.
Yeah, there is a possibility, yes. The location is same. So now two things which Vikas sir was telling, facial ridge and facial bridge. So facial bridge is nothing but a part of the posterior canal wall which is overlying additus ad antrum. Okay, so whatever the part of posterior canal wall overlying additus ad antrum, it is known as bridge. And the part of posterior canal wall which is overlying the mastoid segment of the facial nerve, that is your ridge. So we have to break the bridge first, then lower the ridge. Now I need a thoda sa
Dr.
bhara.
Raman, there are two terms.
Yes,
What
sir.
is lowering of the facial ridge and another is thinning of the facial ridge.
Yes,
Please explain to them so that they can understand.
right. Yes, anterior buttress, posterior buttress. Once you break the bridge, the two bony projections, you see the two ends, they are anterior buttress and the posterior buttress. So now what is thinning of the this facial ridge? So to do the posterior tympanotomy, to see all the landmarks, you have to first thin out the posterior canal wall to its maximum. So that is the thinning of the facial ridge. You can go till the facial nerve, it is going out of the stylomastoid foramen. Then we break the bridge. So the lateral part of the bridge you can do with the drill, but if their ossicles are intact, so sometimes I use curate. It is quite safe because you never know when your burr can just skip and damage your facial nerve or the ossicle. So I sometimes use curate. So now after breaking this bridge, first we are doing thinning. So thin the posterior canal wall to its maximum. The adequate thinning is you should be able to see the reflection of the instrument from one side, or it is called papery thin. Now this end is the anterior buttress and this is the posterior buttress. So we need to drill this anterior buttress also to have a closer view of the anterior, the epitympanum. And also mind it, when the dura is actually in lower down anteriorly and it is comparatively upper in the posterior part. So if you are drilling in the same axis, you will enter into the dura. So also keep changing your approach. So this I am drilling the anterior buttress, and how much you have to lower the facial ridge is, they say, till the facial nerve or at the level of lateral semicircular canal. So if you don't, what is known as a beginner's notch, so if you don't lower the ridge completely, so you have, there might be recidivism. So you need to lower it completely till the level of lateral semicircular canal. Larger size bar.
I think the actual ridge is already lowered when you are seeing the facial nerve for posterior tympanotomy. This is the posterior canal wall part which is remaining.
I can see the piston which is lying there. Is it visible?
Yes, it's visible.
Okay.
Beautiful.
So flush the canal wall or the mastoid cavity with the external auditory canal to have a good result after meatoplasty. So do the canal wall down only when it is required, like indications like if there is extensive cholesteatoma or the cholesteatoma has already eroded the canal wall. In case of promontory fistula or intracranial complications, only then you, or if you're not, if it's a revision surgery and you have a tendency to leave the disease, then always try to do the canal wall down.
Or there was a complication earlier. So if in
Yes.
complication one has to do canal wall down, or patient cannot come in follow-up. even then one should do canal wall down, because canal wall down is safe, and if the patient is from far-flung place, he is not likely to come again for revisit, then it's better to do a canal wall down rather than do some other surgery.
So this is the shadow of the lateral semicircular canal. Here if I am dissecting, I will go into the retrofacial cells. Needle. ये piston आ गया, piston below. Okay, so this is the stapes. I can see the part of the stapes over here. Okay. This is the facial nerve, the white shadow. It's the facial nerve. Okay.
Dr.
I think
Raman,
so.
tell them a
Yes.
little bit about the sinus tympani,
Yeah.
because if we don't thin the facial ridge, we will not be able to approach the sinus
Yes.
tympani.
Needle. So I've already removed the posterior canal wall, otherwise transcanal. This is your stapedial tendon. This is your pyramid. Now this area beneath or medial to the facial nerve, it is your sinus tympani. So this is one of the hidden areas of a mastoid, and you tend to leave the disease over here. So the thinning of the posterior canal wall, it is not only anteriorly. So if you want to access the sinus tympani, you need to drill out thinning of this bone so that your sinus tympani becomes more shallow and you are able to see the cholesteatoma or residual debris, because it is a common site where we don't drill the bone because of the fear of the facial nerve. So the cholesteatoma sometimes is left behind. So you do thinning of the posterior canal wall, or you turn the head of the patient towards you. This is the second thing. Or you can use an angled telescope to visualize the disease in this area. Okay.
Raman, ये तो temporal bone है, इसको थोड़ा tilt करके दिखाओ ना, where is cerebellum, where is ponticulus.
Which one, sir?
उन्हीं के बीच में तो नहीं है sinus tympani.
So sinus tympani is actually the
Medial to the
area.
facial nerve.
Yeah. So this is the subpyramid. Here is the ponticulus,
Yes,
which is
this is the pyramid and the tendon can be seen.
yes. This is the stapedial tendon. This is pyramid. Higher magnification. Let me show. Is it visible?
Focus करो थोड़ा सा.
Focused?
Yeah, better.
So this is your stapedial tendon. This is the stapes. This is the pyramid. Here is the facial nerve. So I can
Yeah,
delineate
about
it
this,
more. So
opening
lateral
of the-
semicircular canal bulge will be here. This is the lateral semicircular canal bulge.
That bulge
This is
about
also
the
a second genie of the facial nerve.
And this is that this process cochleaformis, that bulge anteriorly.
Yes, sir,
yeah,
anteriorly.
Yeah, yeah. That
Let me remove this bone. This is male. No.
facial के ऊपर थोड़ी knob दिख रही ना, that is the thing.
Yes, sir. So this is the oval window, which is in a view. Okay, this is stapes. Stapes foot plate. Okay. This is your second genie of the facial nerve. This is second genu. This is the horizontal segment. and somewhat here it will form the Gasserian ganglion and will form the first genu and then intracranial part. This is your tensor tympani tendon. This is your processus cochleariformis. This is your tensor tympani tendon, which will go out along with the eustachian tube anteriorly. So I think facial nerve decompression can be, you can join for the facial. Have to So while drilling over the facial nerve, you should drill the along the facial nerve. Any important structure you drill parallelly. So separating the facial nerve from or the changing of direction of the bird, this is known as barber pulling. So even if sometimes you injure or damage the sheath of the facial nerve, then you can do a facial nerve decompression. In it, you just have to expose the distal and proximal part of the facial nerve and remove the bone around it and give some steroids to the patient. He will recover in some time.
The second genu is the commonest site of injury, facial nerve injury
Yes.
during mastoid surgery. And this is facial, you should note the relation of facial nerve to the lateral semicircular canal. It is anterior inferior.
Your diamond burr. So I'm using a cutting bar here because this is a temporal bone, but you should try and use the diamond burr with copious irrigation.
To prevent the heat injury.
Slightly smaller. Water. The irrigation should be copious because just by heating effect of the burr, it may cause the facial nerve palsy. So you can decompress the facial nerve all around 180 degree. Now once you expose the facial nerve, the shadow of the facial nerve, then use a flag knife. When a very thin bone is there, so you use a flag knife to just lift the bone all around and use a smaller suction possible. Right? So in this way, just be cautious while removing this bone. You should not cause damage to the facial nerve. Take the bone. So this is a thick bone. You can drill it further, make it thin. Centralized it? Is it centralized? Okay. So you make the bone thin either by drilling or by the flag knife.
You can even use flap elevator.
Yes. Can I have the flap elevator? So this is the thin bone over the facial nerve. I'm just removing it to decompress the facial nerve.
And this is the site where the facial nerve will be descent in almost 1/3 of the cases.
Yes.
And
So around
collapse-
180 degree to 200 degree, you can delineate the facial nerve in the mastoid segment, but here you cannot do it 180 degree or 270 degree. You just anteriorly or anteromedially you can dissect the decompress the facial nerve. So you need to create a plane between the lateral semicircular canal and the facial nerve. So, and changing the direction is barber pulling of the facial nerve. So this is all facial nerve. In the mastoid surgery, first I prefer to do the canal through the canal approach. First I do the middle ear work, expose all the ossicles, pyramid, so that I have an idea where my facial nerve lies. I think this is the facial nerve decompression. Done, sir? Okay. Thank you very much. If any doubt, please let me know.
Thank you, Dr. Raman,
Thank you,
for
sir.
the excellent demonstration.
You,
You
sir.
made the things look so simple
Sir.
and self-explanatory also. And a couple of terms I would like to use here for the postgraduate students.
Yes, sir.
And there is one term, barber polling of the facial nerve. So we decompress the facial nerve in a different direction from different areas. So it is inferiorly in the horizontal portion, then laterally in the second genu, and posteriorly on the
The
vertical portion
vertical
of the facial
mastoid.
nerve, so that we don't injure the chorda tympani nerve and the stapes also.
Yes.
So we change the direction inferiorly, laterally, and posteriorly. Thank you
Right.
so much.
Right. Sir. Thank you for clearing, sir. Okay. Thank you.
I'm saying we decompress the facial nerve inferiorly in the horizontal portion, laterally at the second genu, and posteriorly at the vertical portion. It comes like this, so that you don't injure the stapes, you don't injure the chorda tympani. So you decompress in different areas in different directions, inferiorly, laterally, and posteriorly. Yeah, it comes like this. Dr. Vineet, you can demonstrate. I think you can tell them a little bit about the transposition of the facial nerve. You can decompress fully and just transpose, starting from labyrinthine portion up to the stylomastoid foramen portion. And after that, we can start with the dissection. You have another half an hour with you. Okay. Thank you. Uh, Even I came to know a term. We can, for the sake of postgraduate students, there are three genu in the facial nerve. First genu is at the junction of labyrinthine segment and the horizontal segment, where the GSPN arises. Second genu is at the just anterior and medial to the lateral semicircular canal. And third genu is when it comes out of the stylomastoid foramens and makes a bend. So that is the third genu of the facial nerve. First at the junction of labyrinthine and horizontal segment. Second at the level of horizontal semicircular canal. Third when it comes out as stylomastoid foramen and comes later to the styloid process.
बड़ी सेक्शन दे दो बड़ी 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 so what I am going to demonstrate is the facial nerve decompression facial nerve decompression has been done by Dr. Raman and now we will do facial nerve transposition. Facial nerve transposition basically the first step in your lateral skull base surgery, and the main indication is when you are going for fish type A approach for infratemporal fossa, and this is done to expose your jugular foramen and various pathologies. Most commonly is the glomus jugulaire. So we will do the anterior transposition of the facial nerve. We will remove whole of the facial nerve from its first chenu to stylomastoid foramen, and then it transpose it anteriorly so that the area of jugular foramen is exposed completely. Okay. So first thing we have to do is completely delineate the facial nerve. Is it focused?
Yeah, it's focus.
Okay. So first let me do some this additional work here. In canal wall down, the level of your tegmen should be at the level of your anterior wall of middle ear. So this is tegmen, and I will join this with the anterior wall of middle ear, and we will remove this part of bone to expose the stylomastoid foramen. Okay. Your hands should be stable completely. You have to hold the drill like pen in this position and stable your hands with your little and ring finger like this. Your hand should not be in the air, and your wrist and hand should be in the same axis. यार कोई बड़ी बार दे दो इससे. Now some of this bone you can remove fast because there is no important structure here. कोई दूसरी है कटिंग? कोई दूसरी कटिंग है? कहीं और से बड़ी कटिंग ला दो. So this is, I am exposing the tip cells. There are two types of tip cells. अच्छा, बस बता देना मेरे को. There are two group of cells in the tip, medial group and lateral group. काट नहीं रही यार, काट नहीं रही, काट नहीं रही.
Vinith, is it a digastric ridge which you are drilling? Vinith,
Yes, sir.
was it digastric ridge which you had drilled?
This one.
ना आगे नीचे टिप पे ये
These are the tip cells and
नहीं टिप सेल तो is it digastric ridge?
yes, yes. This bony ridge, what you can see here, which is going anteriorly, this is the digastric ridge, and this digastric ridge divides the cells, lateral cells and the medial cells.
Medial cells.
And what you can see here is what I was trying to delineate. This is the sinus, sigmoid sinus, which is going inferiorly, and it will turn down here and will form the jugular bulb.
Anteriorly.
So what I am delineating is the sinus plate, and the part here is the, this is the pre-sigmoid dura. Now you can see clearly the difference between the texture of this bone and this bone. This is a smooth thin plate. This is your over sigmoid sinus, and there are still loads of air cells are left in the area of the perilabyrinthine air cells. So this is level of my facial nerve, vertical segment, and I will drill all this bone to expose it till the stylomastoid foramen. These are the perifacial air cells, and we have to drill parallel to the structure.
Long axis of the facial nerve. And the size of the cells is always bigger at the mastoid tip.
Centralize, है ना? Now you can see the glimpse of facial nerve, which is direction of facial nerve, which is going like this. So we will sequentially thin out this bone. In live situation, you have to use a diamond drill with lots of irrigation. लो छोटी कटिंग दे दो. One structure which you have to identify here is the posterior semicircular canal. This is the direction of your lateral canal, and this posterior canal, it will come here in this direction. And these are the retrofacial air cells which I am drilling now. Behind the facial nerve. This is the facial nerve, vertical segment. I am going behind these facial nerve to drill the retrofacial air cells. And you can trace the jugular bulb. The outline of jugular bulb. Never try to expose the facial nerve from behind this side. Always leave a sleeve of bone over the facial nerve posteriorly.
मेरी थोड़ा सेंटर करिए, कोने में चला गया. In a live surgery, you can't do with a cutting the burr.
Yes, you have to
You
use
have to use a coarse
diamond burr
diamond
here.
or coarse diamond.
No, sickle knife. Oh, circular knife, circular knife. Yes, circular then.
That is facial nerve sheath.
Yes, now you can palpate it as a soft structure, and you have to remove this soft bone. Now, this is your processus cochleariformis, which marks the first genu, and I am just transposing this processus cochleariformis anteriorly to expose the first genu. Somewhere here deep down is your labyrinthine segment. This is coming here like this. Then this is first genu, and here it takes a turn of around 135 degree, and it forms the tympanic segment. Then it takes a turn of around 70-75 degree, which marks the second genu.
Vinit, center kar pehle.
Yes.
What was the feel of process cochleariformis which you just tried to
Uh,
palpate?
it is a bony structure in which we can feel this is the tendon of your tensor tympani, which is soft structure.
Is it bony?
Now we can start elevating this face.
Vinit, is it bony?
Yes, sir.
Process cochleariformis.
Yes, sir. It is bony.
Then why is it resistant to erosion by cholesteatoma? Cholesteatoma erodes bone.
Yes,
You know
sir.
all this fact.
Yes,
If-
sir.
If it is bony, then it should not be resistant to the erosion by cholesteatoma. It is the last structure which gets eroded by
Yes, sir.
cholesteatoma. फील करके देखो कार्टिलेज जैसा है कि बोनी है बाहर निकाल के हाँ बाद में
Okay.
it should not be
Uh,
because it's the last structure or it is resistant to the erosion by cholesteatoma. So
yes, sir. It looks. Well, it is somewhat harder than the normal fibrous, soft fibrous tissue.
or is it cartilaginous?
Yes. It. Yes. Okay. Thank you, sir. Yes, sir. Sickle knife is enough. Now we will start slowly elevating this facial nerve out of its bed.
So you have drilled it 180 degree.
I have drilled more than 180 degree, not 360 degree. More or less around 270 degree, you can say.
Yes, only posterior part is left, otherwise you had exposed from all sides.
So with a little sharp instrument, you can create a plane here.
You can drill this bone with a smaller burr.
And there are some strong fibrous attachments with the perineurium. I think some more drilling is required here at this point.
If you have Lampert curate, you can just curate it outward. House curate or Lampert curate can be used to curate it out.
Stylomastoid foramen and its fascia. Yes. 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 Okay, yes, some part is left here which needs to be drilled.
So when you look to transpose the facial nerve, usually the indication would be any glomus. When you look at the scan, if it is going anterior and posterior both to the facial. Does the size of the glomus matter? Yes, but not really. Even if you have a small glomus, but it is anterior and posterior to the facial nerve, then to achieve a complete excision, the facial has to be transposed because it's crossing the tumor, because you want full access. Whenever you transpose the facial nerve, you will expect at least a grade 2 or a grade 3 facial paresis because the vascularity gets the best of hands also, because you're lifting the facial from the bed. So deciding to transpose the nerve is a decision to be taken with understanding. Secondly, when you transpose the nerve, despite transposing, there are couple of areas where the nerve can get damaged. And that is why what I suggested to Vineet is to make a groove on the anterior canal wall, which will be a groove running from medial to lateral. And when he finally lifts it, so first thing is you've got to release the entire facial up to the stylomastoid foramen, including the fascia around the nerve. When it exits the stylomastoid foramen, it's like a ring constriction, and that has to be incised so that the nerve is released. Typically, we take a tissue of the perineurium along with the parotid fascia, so it is kept anteriorly. Otherwise, काफी बार क्या होता है आपने transpose कर ली, and then when you're going for the tumor, it can fall back. And as I said, the other thing is to create a groove on the anterior canal wall, so it is kind of a new bed for the facial nerve. Of course, a non-vascular bed, but from the first genu, the facial will run exactly anterior and come out of the parotid fascia. Because eventually such patients are also doing a cul-de-sac. So what he'll do right now is he's going to drill all this, open up the facial here. That's the area of genu. And he should create a groove with a similar or smaller kind burr along the anterior canal wall. So it's rerouting of the facial nerve. यहाँ से facial उठेगी, it goes here and comes out from here. The entire thing moves anterior.
So this is the area of stylomastoid foramen, from where this facial nerve will exit the temporal bone and will go in the parotid tissue anteriorly.
Yeah, so here he still has to knock off this bone. There's a lot of bone laterally. You know, once you do this, no, you have a very clear understanding of where the facial is and how lateral it runs in the temporal bone. So once this is cleared from here, that's his area of the first genu, somewhere over here. So he'll have to create a groove along the anterior canal wall, running medial to lateral, where the facial gently is reflected and the entire nerve is then kept over here and a stitch at this level so the nerve stays anterior.
So there is thick periosteal attachments to the facial nerve in the stylomastoid foramen area, and during live surgery we have to additionally open in the neck and expose the facial nerve in the parotid also. So we can transpose whole of this part anteriorly along with its vertical and horizontal segment. So if we trace this facial nerve, anteriorly this is the soft tissue, this is the parotid gland, and we have to drill. एक छोटी कटिंग देना. So after this, what we will do, we will make a small groove anteriorly in the anterior canal wall here, in this part.
Yes. Create a longitudinal, yeah, yeah.
Now this trough has been created in the anterior part, entry wall of external auditory canal, and now we will lift this facial nerve from its bed. You have to be very gentle in live surgery.
Very nice. Cochlear process पूरा निकाला?
Yes, we have.
Okay. Yeah, that's what I meant. Yeah. Another good instrument is using the side knife here instead of a sickle
Yes.
knife. You can try that.
Side. नहीं वो side knife, flag knife.
Yeah, all that you should release. All that bone, na? It's better to thin it out. All the way down.
विनीत कोड़ा किधर है इसमें? कोड़ा तो या कट गई?
कोड़ा तो सर कट गई. I can try to see from where it is originating.
हाँ. नहीं पर उसका वो
Try drilling the anterior fallopian canal a little bit more. Otherwise, that sharp edge will cause a
Yes.
problem to you.
Yes. डायमंड लगा के देना.
पर वो ब्रांच भी नहीं दिखी थी ना यहाँ नीचे की तरफ. वो रमन कह रहा था जब वो पोस्ट-ऑपरेटिव कर रहा था कि यहाँ पे है.
From there, you'll have the nerve to stapedius also, which you will sacrifice.
This one now to
Yeah,
stupid.
yeah.
Yeah.
It goes to the pyramid, so you'll anyway sacrifice that.
Yes.
Yes.
This is the nerve to stapedius, this branch,
It's quite big one.
which is going in the pyramid here.
Yes. ये आ गई क्या पीछे?
कोरडा.
ये तो उसकी शीत ही खुल गई है.
What he is doing has to be done very gently, like he is doing it, so that the facial is not damaged there. We very often use a curette for this part after thinning the fallopian canal anteriorly, then curette out the spicule of bone.
विनीत तुम्हारे पास उधर हाउस क्यूरेट है तो सही.
Scissor देना. Now you have to cut this nerve to stapedius
Cut it sharply with a scissor.
and cut it sharply. This is the groove which we
Suggest to
have made.
take off that cochlear form with a crocodile forceps, no? It's blocking. Yeah, take it off. Also demarcate up to the first genu nicely.
थोड़ा सा सेंटर करिए, कोने में हो रखा है तुम्हारा फोटो भी आ रहा है बीच में. वो विनीत
Yes sir.
सेंटर करिए.
क्या करो?
नाउ इट इज मच बेटर.
That step is also done very well with a curate if you have one.
Curate है.
Yeah, now you're reaching the first genu.
ठीक है. Actually, we have not separated it from its fibrous attachments in the
Yeah.
stylomastoid foramen, because we have to go deep into the parotid anteriorly, and more or less it is like we have to we separate it from till its bifurcation in the parotid, and then we lift it out of its bed and shift this nerve anteriorly, and we can use tissue glue to hold this nerve in its position in the groove. And now the benefit which we achieve by transposing it anteriorly is the, now this area of hypotympanum, jugular bulb, this whole area is in front of us directly, and we can drill all this area to remove the glomus jugulare, glomus tumor from the jugular foramen area.
And for exactly what's happening now, you see time and again the nerve is dropping back. That's why it's good to take a stitch with the parotid fascia and the nerve. So then when you're operating posteriorly, that nerve doesn't come in your way. Yeah.
So I think that completes the facial nerve transposition, more or less.
Very well shown.
Any questions? Anything else? Now this so much of this manipulation with intact facial nerve will give you at least grade 3 facial nerve palsy in the post-operative period.
ये थोड़ा सा जो labyrinthine segment है उसको भी थोड़ा drill करके direction दिखा दो बच्चों को आगे का भी कि ये greater petrosal है और ये labyrinthine है.
Sir, I have a question here. When it has been transposed anteriorly, what we have done is we have created a. Come back to that side, please. Come back to that.
अरे वो
What we have done is we have given a parallel tunnel anteriorly and we have tried to bring it here. What I have learnt is the nerve is still having that third genu is still is being maintained. We don't need to keep that. Why we don't need to keep that is by giving it a long course in the anterior wall, it will be exposed to many external environment, right? And it will be prone to injury later on in many aspects. So instead of this, what we need to do is, from the first genu, create a tunnel parallel to the eustachian tube in between the carotid and the eustachian tube space, and try to bring out the nerve from here, so that it leaves the middle ear as soon as possible and goes into the parotid tissue. That keeps the nerve less exposed, or else in this way, if we transpose it anteriorly parallel in this canal, it will be exposed to injury later in some way or other. And still, complete transposition, it has to be removed completely from stylomastoid foramen, taken out, and a small course in middle ear, and it goes out of the temporal bone. That's the way it has to be done.
To achieve that, you have to dissect out the
Parotid
now
also.
is the
Definitely,
parotid
sir. So
also.
for
Only then it will
yes,
be
sir.
taken
Definitely, sir.
part-
So when he
entirely.
said that he will be demonstrating fish type A, in fish type A, this is what is needed, or else your nerve will definitely, however, how much fibrin glue you put in here, it will come and fall back in the skin again and again. Still, if you look at the relation with the tympanic membrane, spread the tympanic membrane, how are you going to keep it under the tympanic membrane if you are going to make a tunnel like this and keep it there? You cannot do it.
No, there at
I
the
agree. In that case, total petrosectomy, everything has to be sacrificed and closed it. So that is one way of doing it. But still, giving a small segment here and taking it out will be a better way, I believe. Anterior canal wall. You don't come to the anterior canal wall. You stay in the mesotympanum. From mesotympanum, this is the first genu. You create a tunnel here and come out in the parotid directly. You need not travel all the way in this bone.
तो लेकिन उसमें आखिर लिए पीछे की तरफ जैसे डैड बना हुआ था, ऐसे आगे की तरफ बनाना पड़ेगा, आगे जाएगी।
यहाँ से निकल के इधर चली जाएगी सर।
टिप वाला पार्ट है that has
ये
to be
so that's what I'm saying. In this case, you have to dissect the parotid also, identify trunks there, identify facial nerve in continuity, and then take it out and shift it here.
This actually this anterior whole bone needs to
It
be
has
drilled.
to be removed.
It has to be removed.
Or else there will be sharp bends and it will not be a
Yes.
good thing. Yes, there's no point in keeping it. What is it preserving? Nothing. See, want a decent exposure to, all this why we are doing is to get a decent exposure to hypotympanum. Remove it completely, take it completely away from your field. Nothing, there's no chance. TM joint is somewhere here, it will not be damaged. What you are drilling here is somewhere parallel to the eustachian tube. So there is no possibility of damaging TM joint there. You're not creating a deep tunnel, you're just creating a trough so that the nerve fits in it, that's all.
हाँ जी, हाँ जी। यस सर, ये है ये गोज पीस में निकालो। हाँ जी, ये गोज पीस में रखो, वो छोटा सा है। ये भी उसका पार्ट है। कोई वाइल मंगा लो। कोई नहीं, हम दूसरी बोन में से निकाल लेंगे। यस सर। So what I am drilling here is the supralabyrinthine air cells, and this area belongs to ampullated end of superior semicircular canal and labyrinthine segment of the facial nerve. I'll be trying to show two things here. One is your GSPN, greater superficial petrosulnar, how it originates from your first genu and goes anteriorly, and your labyrinthine segment of the facial nerve, and then we will stop here. Suction पतली थी ना. This labyrinthine segment is in intimate relation with your ampullated end of superior semicircular canal, and there are very high chances of injury to this while you are decompressing the labyrinthine segment of facial nerve. So I think what we have opened here is, this looks like now what you see here is, this is your first genu, this is your tensor tympani tendon which was at the processus cochleariformis, and what you see here is the canal for tensor tympani. This is your canal for tensor tympani, this is your eustachian tube, and superior to this will go the greater superficial petrosal nerve anteriorly. Can you appreciate the direction in which this nerve is going? Deep, and you can see the difference in the diameter of your labyrinthine segment and the second genu or the normal facial nerve. Labyrinthine segment is the narrowest segment. This, yes sir. This is your GSPN. In this fibrous tissue, if I remove this, this is your labyrinthine segment. This thin part which is going deep medially here. This is your first genu, and from this first genu here you can see this nerve fiber arising and going anteriorly. This white fibrous structure, can you see this? This nerve fiber, this is your greater superficial petrosal nerve, which is arising from your first genu and going anteriorly. And this is your labyrinthine segment. ठीक है. Is it okay, sir? Thank you. चलो जी कर लो.
Thank you, Dr. Vineet, for the excellent demonstration, as always. So because of the time constraints, we couldn't go ahead with the labyrinthectomy and other parts. I think the students can get back to their station and start the dissection. And first 5 minutes you have to spend in cleaning your station. I will come and inspect all the stations. It should not be messy. Please go to your station and start the dissection.